Welcome, everyone. I'm Sabrina Darrington. I'm the secretary for the American Society for Bioethics and Humanities. And it is my distinct pleasure to welcome you all to our webinar on DEI, building diversity, equity, and inclusion into bioethics and health humanities scholarship and practice. And today we have a really special panel entitled Clinical Ethics Consultation and Responding to Medical Racism. And I'm just going to introduce our panelists and then turn it over to them. So first we have Gina Campilia, who is an associate professor in the Department of Bioethics and Humanities at the University of Washington School of Medicine and a clinical ethics consultant for the UW Medicine Ethics Consultation Service. Gina's scholarship concentrates on care ethics, critical theory, and counteracting race-based and gender-based oppression in healthcare, as well as expanding the applications of relationality, empathy, epistemology, and feminist ethics to clinical ethics. Then Jennifer James, an associate professor in the Institute for Health and Aging, the Department of Social and Behavioral Sciences, and the Bioethics program at the University of California in San Francisco. Jen is a sociologist and Black feminist scholar who conducts community-engaged qualitative research on the intersection of race, gender, and health. Her current work is focused on experiences of health and illness for people who are or have been incarcerated. We have Alex Olszewski, a third-year pediatric critical care fellow and clinical ethicist at the Northwestern School of Medicine and Anne and Robert H. Lurie Children's Hospital. Alex's scholarship focuses on improving communication, conflict management, and shared decision-making for families and teams in the intensive care unit, as well as reducing health disparities in critically ill children. And finally, Holly Vo is an assistant professor in the Department of Pediatrics at the University of Washington School of Medicine and Seattle Children's Hospital in the divisions of pulmonary and sleep medicine and bioethics and palliative care. She is a pediatric pulmonologist and a clinical ethics consultant for Seattle Children's Hospital. Her scholarship focuses on the process of shared decision-making, improving comprehensive care for children with medical complexity, and advancing health equity. Thank you so much for being with us here today, and we are really eager to learn from you about clinical ethics consultation and responding to medical racism. And as we go into the talk, I would just encourage folks to enter questions into the Q&A part of the Zoom, and we will address those questions at the end. This talk will go for 75 minutes to allow for a really robust question and answer period at the end. So just be aware of that. All right.
Thanks so much, Sabrina, and welcome everyone. Good morning, good afternoon, whatever time zone you're in. We're so glad that so many of you joined us for this conversation today. I don't think you all can see who all is here, but I see lots of names that I recognize, and I know there's a lot of expertise on this topic in our Zoom space, and we're excited to have as much as a conversation as possible in the Zoom webinar format. So you'll see lots of opportunities for participation as we learn together. Go to the next slide, please. So I'm starting us off, and I wanted to start off with a little bit of a grounding, if you will, in why we're here and what we're talking about today. So this is a quote from the amazing Audre Lorde, where she wrote, now 40 years ago, racism and homophobia are real conditions of all our lives in this place and time. I urge each one of us here to reach down into that deep place of knowledge inside herself and touch that terror and loathing of any difference that lives there. See whose face it wears. We raise this for a few reasons. One, because I always love to talk about Audre Lorde. If you need some reading that will fill your soul. I recommend checking out some of her books if you haven't already. Audre Lorde was the person who really, I think, invented the idea of radical self-care as a political act. So thinking about how we think about ourselves, how we think about our place in the world, and how we take care of ourselves as a radical act. But what I wanted to sort of note is that we're here to talk about really serious topics. We're here to talk about racism, the way it affects us all, the way we are all impacted by it, and the way we are all interact in the world from a place of the racism that's embedded across our society. Much of what we're going to be talking about today is uncomfortable. The stories that we'll share from patients and providers, some of those are challenging to hear. And we're asking all of you to be in this space with us and grapple with how we engage in these topics together. That's tough work to do. I hope we all can take care of ourselves in this time and all do the work to really reach deep down into ourselves to see how we engage with, understand, and perpetuate some of these harms in our society. Next slide. So our objectives today are to identify methods to expand existing clinical ethics frameworks and tools to address medical racism and intersecting axes of oppression. We're really here to talk about what we can do in clinical ethics spaces to think about and interrogate and address racism. We're going to apply expanded clinical ethics frameworks to structurally respond to medical racism and clinical ethics consultation. And we're going to discuss ongoing uncertainties and challenges with addressing medical racism in the context of clinical ethics consultations. Next slide. So why are we doing this? Over the last 4 years, especially, and for many decades before that, but over the last 4 years, there have been increasing calls within our field to think critically about racism, to center racism in what we're doing, to have more conversations about this topic, and to think about what the role is of bioethics. In the words of the person we all are expected to quote all the time now, it's me, hi, I'm the problem, it's me. I'm a part of this conversation of thinking about what do we do about racism and stressing it as an important issue. But I'm one of the people who thinks sometimes from 30,000 feet, who theorizes about these ideas, who thinks in broad strokes about these ideas. But I think there still remains a gap of what does this mean in clinical encounters? What does this mean when there's a set of patients in the room, when we're looking at the policies and the structures of one institution? How do we grapple with racism? And that's why we're here today, is to think about and identify some strategies for not just centering racism in the broad, theoretical, important work we're doing broadly in the field of bioethics, but thinking about how do we apply these clinically in the interactions many of us have day to day. Next slide. So just a reminder that when we talk about racism, racism exists on many, many levels, right? And that influences patient care, health interactions on many levels, and the work that many of us do at ethicists on many levels. So of course there's individual racism. Of course that we all hold implicit and explicit biases. We all hold conscious and unconscious feelings. There's things that are externalized that we experience and that are internalized that we bring to interactions. And it's important to center that and to acknowledge that yes, racism and people who we would classify as racist exist in our spaces in healthcare. But more than that, or perhaps more importantly for what we want to think about here, are the ways that systems and structures influence and perpetuate racism. So thinking about institutional racism, the policies and practices at the organization level, at all of our healthcare systems, at the way we organize healthcare that can perpetuate oppression. And structural racism, how things across our entire society, the racist structures of housing and education and the criminal legal system all influence what happens to create a structure that allows racism to be perpetuated in healthcare spaces. And then really thinking about how individuals interact, where racism comes up, and how they interact with those systems and structures. And what I really want to highlight is in healthcare, we talk a lot about healthcare disparities. We know that these racist systems mean that we don't all have equal access to health, to flourishing in our society. But a quote that I love, I first saw this on a t-shirt someone wears, but it's from a really important book by Andre Perry, which is there's nothing wrong with Black people that ending racism can't solve. We're not here to talk about how and why individuals are sick or ill or in need of additional care. We're here to talk about how and why we, these systems of oppression have perpetuated and created a scenario where people are facing really challenging and times of crisis in health and how we can intervene. So we have a few rounding questions that we want to think about in this session today. And that I think are going to guide a lot of our conversations. So first is around what are the obligations of ethics consultants? We know that racism is a pervasive issue in patient care and a key social determinant of health. We know that clinical ethicists, like others involved in patient care, have a duty to recognize and respond to racism on both individual and system-wide levels to improve that care. ASBH has guidelines recommending addressing issues of disparities, inequities, and other systemic issues, but often we don't have good guidance on how to do that. So we want to really interrogate and understand what are the ways and the potential for ethics consultation to perpetuate racism, to cause harm in our interactions, and what is the role of the ethics consultation in broader practices of transformative justice? Do we have tools to intervene and to help issues of racism, to understand, identify, and intervene in some way? And are there ways in which our field is a part of perpetuating harm? How do we understand how to do that? So we're going to get into some case examples where some amazing clinical ethicists, my co-panelists, have thought about this in depth. But we do want to first start with a question for all of you to bring you into this space. So throughout this event, we're going to be using Slido to do a few moments of audience engagement. So you should be able to take your phone and scan this QR code or go to slido.com and enter this number 3167231, which you can then keep up on your computer or phone for the rest of the webinar to answer some questions. But we wanted to just start with getting a sense of how people feel on this topic, so on a scale of 1 to 5, 1 being not at all confident, 5 being very confident, do you feel like you know how to identify and address racism as it comes up in an ethics consult? So when there's issues of racism that come up, when you're working in the clinical setting, do you know what to do? Do you feel like you have the tools you need to do it? We're seeing some answers come in. I love that we can see it in real time, see it moving. It's very exciting. Give it just a minute as some folks, it seems like most folks are falling in the middle. We have a very nice bell curve representation here at the moment. Lots of 3s, maybe not so sures, with a few more 2s and 4s. But only a couple people have said 5. They definitely know how to identify and address racism, which I think speaks to why we're all here today, to identify some potential new ways of doing this. All right, looks like it's settled. So it seems like most people are right in the middle, not completely unconfident, but not very confident at all. So let's see if we can help move the needle or at least challenge all of our thinking on this in the next few minutes. Ollie, go for it.
All right. Thank you, Jen. So here I'm going to talk about some of the goals and challenges that Jen brought up in some more detail. So clinical ethics consultants, as Jen mentioned, are uniquely positioned to address racism. For example, they can draw on their strengths from the multidisciplinary field, as well as they occupy positions of power in that they can facilitate dialogue and make recommendations that can change the course of a patient's care. However, Jen also mentioned, while ASBH implores ethics consults to address systemic issues, common methodologies and tools provide little guidance on how to do so effectively. And I think the poll that we just saw is reflective of some of the feelings of the lack of tools that are out there to help us all. So addressing racism and other forms of oppression in the clinical encounter can be challenging. Like other skills and ethics consultants, our consults may benefit from specialized training, standardized tools and approaches, as well as practice. We can learn from existing frameworks and tools, as well as build new ones, so we can help guide clinical ethicists to systematically approach racism as it affects clinical cases. Ethics consultants typically rely on various frameworks and tools to approach the consult process, and here you'll see some that are commonly used by ethics consultants here in the United States. One of the more popular frameworks is based on Beecham and Childress's principles of biomedical ethics, which highlights the principles of respect for autonomy, beneficence, non-maleficence, and justice. And these 4 principles are widely taught in clinical training and familiar to many healthcare providers. There are some tools to support ethics consults, such as the 4-box method, VA cases approach, and counter storytelling. And here I'm going to talk through how we use the existing 4-box method and expanded it to provide a tool for ethics consultants to use that can help systematically approach racism as it affects clinical cases. For those that aren't aware, the goal of the four-box method from Johnson, Siegler, and Winslet is to help ethics consultants work through difficult cases by organizing information in 4 topics: medical indications, patient preferences, quality of life, and contextual features. And each of these hold the same amount of weight in deliberation. Once you get the details of a case, there are a series of questions that you can ask. And these questions are grounded in the 4 principles. Although there is mention of addressing racism in relation to bias and quality of life judgments, the existing 4-box method doesn't explicitly address how to identify racism as an ethically salient dimension of consults. It doesn't really offer clear structure for organizing that relevant information. In clinical practice, concerns about race or other axes of oppression generally be ignored, or they generally get relegated to this last box labeled contextual features, which is where we are typically taught to include issues related to justice and fairness. However, as Jen already said, racism permeates through all institutional practices and is implicated in all aspects of ethical decision-making. And so therefore, we feel that it should be addressed systematically by including recognition and analysis of racism throughout each of the 4 topics. Therefore, we propose expanding the 4-box method as one strategy to help clinical ethicists identify and address different manifestations of racism in ethics consults. Here, we focus on addressing racism, specifically anti-Black racism. However, the expansion of the 4-box method is intended only as a first step in addressing all intersecting axes of oppression. This table here illustrates an expanded version of the 4-box method. We'll go into this more into detail, so no need to absorb all the text on this slide. But what we tried to do was include additional questions and change it to existing questions to ensure that racism is addressed within each box. Ethical domains such as resource allocation, shared decision-making, informed consent are all impacted by racism. And so by acknowledging how pervasive racism is throughout a patient's healthcare experience, throughout the 4 boxes, we can allow clinical ethicists to identify and highlight areas of potential power imbalances, biases, and institutional practices and behaviors that may be discriminatory and oppressive. For example, focusing on the first box, this is about medical indications, and this one is grounded in the principles of beneficence and non-maleficence. In addition to what it's leading us to do, which is to think about the patient's medical problem and if the problem is acute or chronic, critical, or terminal, we urge clinical ethicists to consider what racist policies, practices, or prejudices may affect the patient's diagnosis and treatment. For example, we ask, how might current clinical training and tools be impacted by biases and racism in the assessment of this patient? We know that due to structural racism, there are some clinical algorithms that are developed based on biased data sets or rely on incorrect assumptions, and this results in healthcare disparities. By asking how racism plays a role in the diagnosis and assessment of a patient can inform the clinical ethicist of whether the medical indications are actually appropriate for this patient. We'll plan to present a detailed example of how to use the adaptive 4-box method using a case in just a few minutes. But before that, we wanted to also present this framework for ethical analysis grounded in transformational justice. So, motivated by practical expertise of clinical ethicists, we offer a framework to support openness to analyzing power imbalances and respecting marginalized voices and values. This framework is grounded in transformative justice, where the aim is to take responsibility for oppression and then center and respond to moral perspectives and values that are just too often silenced. And so we organize this tool by ethical approaches that are reflective of many shared values held within and outside the 4 principles. And it's not meant to be new or exhaustive, but we'll go into more details of why we put each of these in. Then we offer key questions as well as tips and considerations. And though we don't provide a comprehensive conceptualization of each of these components, we do offer questions and considerations for practice, as we'll see in an upcoming case. Ultimately, the goal is that we want to be able to hold all of these ethical approaches together so that one doesn't automatically outweigh the other just because it's a more dominant moral value here in the United States medical culture. So now we're going to pivot and demonstrate the application of these tools and frameworks to cases. Of note, these are based on real cases. We've changed details to protect the identities and stories of our patients and families. And we recognize that sharing narratives can be an appropriate way for speaking for others. And we've done our best to take care and share these narratives in a way that really elevates the voices of our patients and families. So Olivia is a 6-week-old infant who was born premature and has severe hypoxic ischemic encephalopathy from placental abruption. She is currently admitted in the neonatal ICU. She requires invasive mechanical ventilator support and intensive nursing needs. After therapeutic hypothermia, she remains profoundly neurologically depressed, but does grimace to painful stimuli. The medical team is concerned that the life-sustaining interventions being provided are, quote, futile because the patient has no future. Additionally, the medical team is concerned the family just doesn't get it and perceive them as difficult because they're rarely at the bedside and they've been reported to consistently raise their voices towards staff. So the medical team consulted ethics regarding concerns, again, about, quote, futility of continuing life-sustaining interventions, as well as the possibility of initiating a behavior contract owing to perceived aggression from the family. The ethics consult process that occurred for this case started with the ethics team receiving a consult from the primary NICU team. And then the ethics consultant then went to interview all engaged parties, which includes the primary medical team and the patient's family. And once the ethics consultant is able to listen to these various perspectives, they can start the process of facilitating communication about values. And Alex will now pick up and discuss how this process unfolded.
Thanks, Holly. So we'll start with sharing what the ethicist learned about the family's perspective. So when meeting with the family, I think from what Holly just framed, you got some of the clinical team's perspective and reasons for the consult. So when the ethicist met with the family, they learned that the family believes they've been treated differently because they're Black. The family asserts that they've actually participated in lots of discussions, expressed their wishes many times that they want to continue sustaining intervention, and they are confused as to why the team keeps wanting to have these conversations. They use the phrasing that they feel that their goals are constantly questioned. And so that led to them asking the team to limit these conversations around goals of care. They describe that the team continued to push them about the goals of care despite this request, and that has led them to feel frustrated and distrustful and then to express those feelings to the team. And then some additional context you gather is that the parents have not been able to be at the bedside due to several barriers. One is just employment issues with both of them working. Another is transportation difficulties with them living far away from the hospital. And then this case took place during during the COVID-19 crisis with stricter policies in place. And because of the restrictions with only one visitor per day, it has made it very difficult for parents to be at the bedside while also finding care for their other children. So we're going to take some time and jump back into Slido before we kind of talk through how we worked through the analysis of this case. Some of the questions that we want to work through and get your perspectives on are, how might anti-Black racism be operating in this case? How would you gather information to better understand how anti-Black racism might be operating in this case? And what tools or frameworks could you use? So certainly we have started to show you some tools that we propose, but we'd love to hear other people's ideas as well. So we'll just start going through those questions one at a time on Slido. The first one is, how might anti-Black racism be operating?
And just a little logistical thing, if you refresh your screen or your phone, the new questions should pop up from the prior browser you had open.
Great. So seeing several people calling out the labeling of the family as difficult and aggressive. Ooh, I didn't know it was going to slide away from me. Not honoring their requests, the strict policies and how they might disparately affect people, assumptions made about the family, both about their background and their resources. I'm seeing comments about historical distrust, putting blame on parents rather than kind of trying to understand the limitations. And then I saw something earlier too about coding language, this language around sort of family not getting it and making assumptions about their understanding. A paternalistic impression of knowing what we think is better. Policing of Black parents and not assuming the best intent for people when they're not available to be at the bedside or not learning about how we could better support that. Great. A lot of comments on this aggressive label being important and sort of the racism implied in that. A really interesting comment that judgments about futility might have a different bar. I think getting at sort of who are the families that clinical teams either label as aggressive or difficult, or are more likely to do that, and who are the patients that we worry about futility in. Like, would an ethics consult be called for every baby with severe neurologic injury, or are there features, including racism, that are participating in the team having that bar to call an ethics consult here? Great. We can go on, I think, to the next one. So then this gets to a lot of the goals of this conversation today. How would you start with gathering information to better understand how anti-Black racism might be operating? So first of all, talking to the family and to the care team, and then phrasing people are offering, what has your experience been of bias with healthcare? How have you experienced healthcare in the past? I think are really great ways to sort of start the conversation. Collecting data on demographics, so sort of big picture over time, tracking which patients get ethics consultation, including looking at their demographics. If anyone else in my panel is catching ones that I'm missing as these go through quickly, feel free to talk too.
I'm just seeing so much about creating spaces, about listening, about making opportunities for conversation, which is wonderful.
Great. If you are not a Black provider, do some self-reflection and self-awareness around your tone, body language, use of language. So I think that's a really important one about thinking about yourself as the ethics consultant and your role in this, and then thinking about the medical team members that you are trying to help in this consult. Create space for staff to share their perspective and to reflect on their own biases. Great. And then pushing people when you do get, I think, perceptions, I think this is more for the staff, but get the staff you're talking to articulate their reasons, to kind of push them to potentially recognize their own assumptions and evidence or lack thereof.
Something I'm really noticing that I didn't know Slido was going to do is just like the counting on the top, but I think it's really showing how people it's multi-directional. Like, you're both engaging the family and the team. Like, people are really speaking to creating conversation in multiple directions. It's not just, there's not just centered on one group, which is interesting and great.
That's a great comment too, checking in with the family to see how they are perceiving the situation. I've seen different people commenting about being open-ended in your conversations too, so not assuming that there is an anti-Black or that the family is perceiving the situation as involving anti-Black racism. Be direct with specific questions and explore historical distrust. Great. Okay, I think we could go on to the next one. And then especially kind of expanding beyond some of the tools and frameworks that we're going to talk about today, we'd love to find out if people have tools or frameworks that they have found useful. Great. So empathy, narrative humility, and using your resources, using an equity team, making sure that all stakeholders have a voice and that you're applying an intersectional lens, counter narratives and perspective taking and centering the family. I think a lot of like commonality there. A tool to help people imagine opposite perceptions, and then like looking into what resources your institution has. Transparent language with staff, and pushing people to reflect on if a situation would be different if the race or other kind of oppression-based factors would be changed. Making sure the bioethics community has racial diversity in it, has racial diversity in it, I think is a huge one to work on over time. Great. Understanding data about social determinants. So in addition to this like really important comments about being patient-centered, team-centered, gathering perspectives, also doing your own homework on sort of how social barriers exist differently for different groups. Have more like regular rounds around these discussions to normalize them, and to train yourself and your team in workshops and other educational offerings. Managing shame reactions and deflection with advanced framing is a really cool point. And confronting our own assumptions. Anything anyone has to add? I see you typing some stuff, Joe.
I was just pulling out some people were mentioning some specific tools. I was trying to note them down. So if I think that the chat is open. If people have links to resources and they want to share, please include those there and we can make sure we share them out with the notes and additional materials.
Great. Okay, I think we can keep going. We can skip over this. Yeah, actually, someone asked this, examples of advanced framing. Does anyone on the panel have insight into that? Okay, we can move on then and try to get at that at the end. So this is backing up a little bit and talking through the process in this ethics consultation. And I think some of the factors here have been brought up by the chat. So in your interviews, making sure you do speak to the family and work to center their voices. I think we've all been touching on this in our answers and how we've sort of been talking through this at the beginning, but thinking about how you as an ethics consultant might be perpetuating harm. So if you take the team's assessment at face value and you you don't question it, thinking through sort of what power you have to provide an ethical analysis that supports restricting the family's decision making, that supports a behavior contract and the policing of the family, and that doesn't push the team to consider alternative approaches. This also gets at this issue we've started to talk about around who gets ethics consultation and in which patients do clinical teams worry about potential futility. Is it every baby with severe neurologic injury, or are there factors that are influenced by racism and other axes of oppression that are leading this consult to happen? We know that labeling of families as difficult, that ethics consultation themselves, security calls, other sort of restricting and policing types of decisions, including behavior contracts, are all more common in Black children and Black families than they are in white families. And so again, this with ethics consults being one of those ways that clinical teams might be seeking to limit a family or to in their decision making, or even to police them in terms of making decisions like behavior contract use. Ethics consultants have this really unique role where you can either participate in or perpetuate bias or work to expose it. And then this has come up in the last question answer too, is using your resources. And I think that will be a cool thing to talk about at the end, sort of what types of resources do different institutions have in terms of health equity consultation and services. And then the next step, once you've gathered data and used the resources that you have to help you with that, is sort of the analysis piece, the identifying and clarifying what you are going to work through in your analysis. One way to do that is to use the expanded 4 boxes, and we'll talk through that. But I think highlighting in your analysis, thinking through the family's experience with unfair treatment, how respectfulness and fairness are seen by them, using anti-racist and trauma-informed approaches specific to the issues that they bring up as being important to them, rather than, as someone pointed out in the chat, assuming that they're facing those things. And then using this broader analysis that considers anti-Black racism throughout when you think through the risks and benefits of different pathways. And then as you organize your information from different perspectives, think about using counter storytelling as you sort of summarize the information you have. So counter storytelling is a way to sort of center the narrative of the more oppressed group, or the group that has less power, in order to both bring that view forward, but also to expose the oppression of the dominant narrative. So we'll go through a couple of the 4 boxes and sort of how we thought about them in this case to give you an idea. So in the medical indications box that Holly went through, what you can see here is not bolded are the sort of old questions that the 4 boxes method pushes ethicists to think through. And then what's in bold are the parts or the questions that we added to this box in order to have a more systematic way to look at these issues around anti-Black racism and other axes of oppression and how they affect each of the boxes. I'll go through parts of this. So the first sort of part of this is not focused on anti-Black racism at its intersection. It's just sort of the basics around the patient's medical problem. So they have hypoxic ischemic encephalopathy. They are ventilator dependent. The prognosis is that they have a poor likelihood of neurologic improvement. They're likely to remain in a similar neurologic and medical state and need similar medical support throughout their life. The next question asks, what social contextual features might affect the approach to this patient's diagnosis and treatment? So I think one important feature in this approach is it pushes you to think about both what the family might be facing at the bedside now, and also what sort of contextual and historical features might be influencing the interaction between the team and the family. And so in this case, thinking about the disparities that exist, Black infants and their mothers have worse outcomes across many domains compared to white infants. Black infants are more than 2 times as likely to die in the first year of life in the United States, and they have about 3 times the rates of being very low birth weight and born preterm compared to white infants. In this case, the source of some of the patients' diagnoses was a placental abruption, and Black mothers are much more likely to have placental abruption compared to white infants. So I think the factors that lead to those disparities are very multifactorial, but some of them sort of fall into the different boxes of racism that Jen talked about earlier. So you have different differential access to resources and healthcare, which are more institutional forms of racism. You have the discrimination and trust issues that families face when interacting in the healthcare system, so including interpersonal and personally mediated racism. And then these factors all influence the clinical team's judgments and the family's trust. And then the clinical team's assessment also is influenced by the family's social circumstances and their ability to be at the bedside and the resources they have at home. Skipping, just showing you sort of how some of these questions might be answered in a real case. So what used to be the question is, what are the goals of treatment? Adding in things to help you think through and center different voices. Who participated in defining these goals, and has the patient's, or in this case, the family's voice, been given equitable space? So goals of treatment, as they're summarized by different people you interview, are respiratory support, nutrition, some people talking about the importance of comfort and minimizing suffering. And then the family brings up that some of their goals of treatment are keeping the family together, all the siblings together and feeling cared for and feeling like they are good parents who don't give up on their child. Then in terms of who has participated, making sure you ask that again, like thinking through why we're going through these boxes. If you ask these questions, it will help you be systematic in your approach and make sure you're not missing anything. So if you're thinking through the goals of treatment in this box and you ask yourself who participated in defining these, it might push you as an ethics consultant to think, oh, I guess I mostly got those from the clinical team. I should go back and think through who else has an influence on goals of treatment and make sure I gather their perspective. I think that's one way to think about all these questions in the boxes. And then, has the patient's voice been given equitable space? And I think in general, it doesn't seem like that in the way we've been sort of portraying this for you. Going to the second box for patient and caregiver preferences. This one is long and has a lot of factors. I think it used to be pretty centered around sort of what are the patient's or family's preferences and are they capable of making decisions. Some of the questions we've added in are sort of helping people think through what axes of oppression might be influencing each of those. So how are race-based and other forms of oppression obstructing communication about preferences and benefits and risks? How are they obstructing maybe the family's understanding of the information and their ability to truly provide consent? Have family members really been informed of the benefits and risks, and do they understand the information? And if so, has there been equitable space provided for their voice and preference? And then what a question used to be, is the patient having difficulty engaging in decision making? But I think expanding that to, is the patient and the medical team having difficulty engaging in shared decision making, to again sort of give you this bidirectional way of looking at what might be leading to a conflict in decision making. So summarizing some of the things that sort of fell into this box in our analysis, some of the clinicians' perspective was that the family is in denial, that they don't understand the diagnosis or prognosis, that they don't participate in care, that they can be escalated and difficult to communicate with. The family's perspective is that they very much understand the condition and the prognosis, that they have made an informed decision, recognizing the risks and benefits, that they would like to stop or limit the discussions around goals of care because they feel like they have already engaged in that, and that they want to also have some space to discuss the next steps within their own community in terms of how care would be provided outside of the hospital. They feel that their communication preferences were not honored. And then adding into this box and its analysis, the disparities in outcomes and the historic and current experiences with healthcare teams may be impacting the trust of Black patients and families. And then hospital policies, social cultural differences, and clinician biases may be influencing the parent's ability to engage in discussions as they would like. One thing I want to point out too with the use of these boxes is what we're writing here is what can go into sort of what you share with the team in terms of your analysis and what goes into your notes. So this is also a way to sort of organize your own thoughts, but then organize how you communicate them as well to the team. This is in our paper where we go through all 4 of the boxes and how we applied them, and we'll share this at the end. We'll move on to sort of talking through the outcomes of this case and then some discussion around how we document these things. We'll skip over this and have Gina spend a little more time on it. So I think documentation comes up as a tricky area where there may be some awkwardness and sort of challenging implications in documenting concerns about anti-Black racism or other ways that the team may be engaging in oppression. And so I think the first thing to point out in this, or the first tip we have around this, is making sure that you have shared your thoughts and your analysis verbally with everyone, both the team and the family, before you document, so that the written documentation is not the first time people see your discussion around these more sensitive topics. And then I think the other big thing to remember is that racism is already in the chart in many ways. And so you are not providing something different, but you're not sort of newly bringing racism into the note, but you are doing it hopefully in a way that helps to raise awareness and mitigate its harms. I think the other way to talk through this is, what if you don't call out the potential harms and risks of the racism that you encounter and recognize in your analysis? And then this approach, or one like it, doing this in a systematic way across all ethics consultation, is also a way to sort of normalize this analysis and normalize the way you discuss it with clinical teams, so that it is sort of taken as a useful, helpful strategy for teams, and hopefully not in a way that is personal and taking it as an attack on them. Yeah. So some of the outcomes in this case, as we've started to touch on, the family's narrative was centered, and we used that narrative itself to really expose the racism and biases in the clinical team's assessment, approach, and policy application. A lot of you were mentioning this in your tips on how to interact with this case. So if you center the family's voice and bring up their experiences, and if you question the clinical team's assessment and approach, you will hopefully bring people to understanding some of the way these factors are interacting with each other. These are centered mostly in narrative ethics and the use of counter narratives. There was a care conference for both sides to share their perspective, so more focused in narrative and care ethics. In that care conference, there was an intentional focus on sort of, this is the practical outcome, bi-directional expectation setting with the family and clinicians, each sharing their rules and boundaries for communication. So as opposed to bringing in a behavior contract, which is often focused on what the family is allowed to do, and adds sort of a contractual element to it that can feel quite punitive, and can lead to families being taken away from the bedside. Doing that in a way that's bi-directional, where the family gets to ask the team for their goals and preferences in communication, and the team gets to do so as well, and everyone can agree together on their limits along those lines. So focusing on harm reduction and using care ethics in that. And then this is a big picture outcome that we also hope to advocate for in your work in ethics consultation in general. When you see problems come up, and especially seeing the same type of issue more than once, thinking about how you can use the ethics consultation and the problems you identify to change policy. So in this case, a group got together to evaluate the COVID-19 visitor policy using a multidisciplinary committee and applying a health equity impact assessment, and working through that over time, recognizing the disparate ways that the visitor policy was affecting some families differently than others. We implemented different changes to both mitigate the harms and to change sort of how the policy was used. So focusing there on harm reduction and justice principle.
Thanks, Alex. I'm going to shift us to a different case. And for this case, while for the first case, we focused in on the beginning part of an ethics consultation where you're gathering information and organizing and categorizing that information, we're going to shift towards the analysis part of ethics consultation. And so we'll start like Alex did with a case. So case 2 is Angeline, who is a 40-year-old with rectal cancer diagnosed 10 years prior. She's been receiving chemo and radiation at an outside institution, but she's presented to the ED with her 2 sisters after experiencing 24 hours of severe abdominal pain and bloating. She was found to have toxic megacolon, a rare but treatable condition that is characterized by dilation of the colon plus systemic toxicity. The medical team has recommended surgery to reduce the size and prevent perforation of the colon. However, Angeline has declined surgical intervention. Angeline has decision-making capacity and she's been assessed, but relies strongly on relationships with 2 sisters as well. And so when she feels ill, as she does intermittently, and then intermittently engages in decision-making because of how she feels, she sometimes defers to her sisters, but over time has clearly and consistently declined surgical intervention, citing concerns about the numbers of interventions, concerns about exposure of the abdomen, and belief in God's ability to protect. Though the team believed that she was a candidate for more immediate surgical interventions, they have tried alternative treatment approaches with the hopes of avoiding surgery and at the patient's request, of course. However, there has been no reduction in the size of the toxic megacolon, and the medical team fears that without surgery, the colon could rupture and Angeline could die. Next slide. Angeline identifies as an African-American cisgender woman. She lives in an apartment outside of the city with both sisters nearby. She has been living with her cancer diagnosis, as we said, for several years, previously declining surgical interventions while accepting non-surgical interventions like chemotherapy. She has been previously told that she needed life-saving surgery, but declined it and survived without that surgical intervention. She is not well known to the hospital and primarily receives cancer care at an outside institution. Members of the healthcare team have focused on engaging with Angeline to understand her reasoning and declining this potentially life-saving surgery, but also wanting to live longer. Angeline and her sisters describe feeling badgered by questions from the team and share that the team was not respecting Angeline's decision-making authority. Angeline describes feeling, quote, uncomfortable sometimes in the approaches taken by clinicians, stating concerns about being treated, quote, like a guinea pig. The medical team describes feeling distressed and is uncertain about how to move forward with Angeline's care under what they perceive to be increasingly urgent circumstances. Next slide. So like with the last case, we'd like to gather your input on what you're seeing in this case first. So for me, this is one case among many that raised the urgency of asking questions as an ethics consultant and finding systemic approaches to recognizing and addressing anti-Black racism. And I have 3 questions here. The first 2 are what we'll focus on to start, which is how do you see or might you be concerned about anti-Black racism operating and what you know about the narrative from what I've told you so far? You can open up the Slido, Holly. Based on what you've been told, maybe what questions would you ask, or how do you already see evidence in the narrative that's pointing to anti-Black racism in this case at interpersonal or institutional levels. Not prioritizing the reasons for her choices, I assume over medical reasons. Good. I think there are many assumptions at play, historical mistrust in the medical system caused by the medical system, questioning her capacity and her understanding. Good. The belief that Angeline doesn't appreciate the risk, right? This might lead to questioning of decision-making capacity. Great. Yes, dismissing and blaming, even taking a more paternalistic approach. Skepticism. Good. The patient's reference to being treated like a guinea pig should be addressed. Good. Mistrust, feeling belittled. Disregard for historical experiences of Black community being tested unethically and harmfully. Yes. Yes, the possible dismissing of spiritual harm as irrelevant. Good. These are great. Next, I'll move along just because I have time. Next slide. Thanks, Holly. These are all, many of you recognize exactly the sorts of things that came up for me when I was initially called about the cases that this is based off of. And so, as I said before, there are so many things to think about in the beginning part of the ethics consultation process, how we interview, identify, clarify, and organize this information. I'm going to focus on the latter half, but I'll speak quickly about the first half. Next slide. So for me, going into a case like this as an ethics consultant, I want to, in the interview process, thinking about how to center the voices of Angeline and her family, consider how I, as the ethics consultant, can perpetuate harm in ongoing conversations and being aware of that. Potentially consulting, if it's available, health equity or JEDI expertise or service at the hospital in that process. With awareness of the possibility of perpetuating racism rather than counteracting or preventing it. I want to know more about Angeline's experience with unfair treatment. It would be important to ask about the mention of being treated like a guinea pig and where that's coming from, as well as asking Angeline and her sisters what respectfulness means to them. I think somebody asked a question about how can you ask about some of these things? And I think that's especially important given our different positionalities. Questions can come across differently. And so one of the questions I often rely on is, what does respectfulness look like to you or mean to you? Addressing anti-racist trauma-informed approaches specific to Angeline. I'll talk more about that in a minute. Urgency of interventions per the medical team. So questioning, as Alex talked about, the medical team's perception of the urgency and then risks of different pathways from all perspectives. And then organizing that information accordingly, reviewing and going back to patient and family to make sure that I've understood them correctly and that I'm in retelling their story in the chart, that I'm carrying a narrative forward that makes sense to them. And we'll skip through the next couple of slides quickly. So I did, for the purposes of the PDF we'll share later, I did go through the 4 boxes, but I won't speak in detail of them here because I want to get to this question of the ethics consultation process and how we perpetuate as ethics consultants, how we might perpetuate anti-Black racism. I'm going to skip over the Slido for now because I think we'll talk about it in the Q&A, but I want you to be thinking about that question as we go forward. And I think that for me, yeah, this slide's perfect, Holly, thanks. One of the main additional ways in which we can perpetuate racism, on top of what Alex has already discussed, is in how we name the ethics question or conflict, and then how we analyze. And so one of the ways to frame this question is is not just to say there's a conflict between the obligation to respect Angeline's autonomy and prevent harm to Angeline or secure benefit for Angeline, but there's a way in which we can actually focus this question through the lens of an anti-racist approach. So understanding that anti-Black racism is impinging on both of those things. So racism places Angeline at greater risk of morbidity or mortality and of disrespect of agency and autonomy. And so that matters to how we frame the conflict. It can also heighten the urge to protect saviorism, just as it can heighten the bar at which decision-making capacity is assessed. And so those are some of the questions we want to wrap into the framing of the ethics question and the analysis. So next slide, Holly. And so what, this is just a start. I can say that alongside my co-authors, some of whom are here, and many colleagues inside and outside our institutions, as Holly described, we've tried to find some framing for not a way of abandoning the approaches many of us already use, like the 4 principles or many of the core values you see here. These are approaches that have been used across societies and centuries. And so what we're trying to do is to expand, include, and recognize the ways in which power and privilege intersect throughout all of these core values that are often important to ethics consultation. And so first, thinking about consequences for Angeline, I'm just going to say a little bit about each of these. There's so many details to think about, but the consequences of continuing to pressure or even compel surgical intervention, even in the context of emergency, may not only be violating of Angeline's autonomy, but also violent in action and have serious consequences for both Angeline, her family, and her community. And that needs to be factored into the analysis of the consequences. Second, thinking about obligations. Respectfulness and fair treatment, core moral obligations, should include attending to the historical trauma of racist objectification of patients and violence against patients as objects of study, as well as directly asking, as I said before, Angeline and her family about what respectfulness means to them, what experiences they have had with unfair treatment. And then virtues. Humility and curiosity can be key components of counteracting racist judgments about clinical diagnosis, risks, goals of care, and so on. And relationships. Building therapeutic alliance through recognition and sometimes needs to take priority even over medical decisions or interventions, especially when there's historical trauma of medical racism and contemporary triggering of that trauma. And so focusing on those first two, consequences and obligations, for just a second, we shift our ethics question, right? Not, as I said before, it's not just about respecting autonomy versus protecting a patient for harm, but how do we understand balancing the risk of harmful consequences for Angeline, knowing that saviorism could be biasing the urge to protect, and that racism puts Angeline at a greater risk for harm as well, against the fact that anti-Black racism alongside sexism could also be unfairly heightening that bar at which we assess decision-making capacity and making healthcare professionals and ethics consultants expect more from Angeline or unconsciously look for ways to override autonomy. Next slide. So I know I'm only barely touching on these because I really want to get to the questions. So for recommendations, I just wanted to, thinking through each of these frameworks led us to certain recommendations. And I wanted to show you something like what this might look like in the chart. So given Angeline has decision-making capacity, it is not ethically justifiable to pursue surgery over Angeline's objections. Second, given that surgery is urgent but not emergent, take a pause. The obligation to build trusting relationships and respect relational autonomy supports taking a pause for 1 to 3 days in medical decision-making. While this risks some harm to Angeline by delaying surgery, It is critical to both avoiding causing further trauma and respecting Angeline and her family. Next slide. Recommendation 3 builds off of these first two with a focus on relationships, balancing respect for Angeline and her family's preferences and protecting her well-being cannot be accomplished until the family's perspective is fully recognized. Rebuilding trust, respect, and caring clinician-patient relations requires at least recognizing the patient and family's experiences with racism in medicine and how they relate to the history of medical research, specifically recognizing those concerns about being treated like a guinea pig, and then spending time to understand more about Angeline and her family's narrative. Again, this is all putting aside the medical decision to focus on this. Next slide. And then reconvening, and partly separately as an interprofessional team to address biases that are coming up, to actually talk about them openly, share information, and develop a consistent patient-centered approach. Next. And then also engaging consulting services that might be supportive, including equity consultation services, palliative and spiritual care, wherever it makes sense, to assist with conversations about goals of care. And so before we get to these lingering questions, and you can leave the slide there, Holly, if you want, I just wanted to share the results of what happened for the case that this is based off of. We did pause conversations because the surgery was not emergent, and there was some time to do that, and focused on building and understanding and addressing racism and biases related to it, and pulled in outpatient providers who were trusted by Angeline to also better understand the history of her decisions and values, and we found ways to address some of the disrespect Angeline was experiencing, for example, in even just daily cares where healthcare professionals might not normally seek consent. There was a slow process of explaining everything that was being done cautiously and carefully, and seeking consent for everything along the way, even small tasks, for example. And then over time, in more conversation, it turned out that actually Angeline started to get better, and she didn't have toxic megacolon and was able to be discharged. And so I think it's a lesson in also humility and curiosity for me in particular as an ethics consultant. I think in this case, I learned that I took for granted the medical diagnosis and didn't question it. And so that's also an important thing that I've really taken away from here. It wouldn't be true in every case, obviously, but an important factor for consideration. I'll turn it over so we can get to questions.
Yeah, thank you so much. And thank you, everyone. We have, I think, about 10 minutes for questions. We have a few more slides we can just keep going through as the panelists all come back on screen. And as we invite you to start putting questions in the chat and the Q&A. I wanted to thank my 3 co-panelists for sharing these incredibly important stories of patients and teams engaging in difficult conversations and on difficult topics. And I wanted to just do a few reminders as we get into questions. First, one of my favorite works on racism that I read so long ago now was Beverly Tatum's book, Why Are All the Black Kids Sitting Together in the Cafeteria?, where she describes racism as a moving sidewalk, that we are all on it already. We are all a part of perpetuating racism, experiencing racism, unless we're explicitly running backwards away from it, right? And so this Angela Davis quote that it's not enough to be non-racist, right? We have to be anti-racist. And you can keep going forward in the slides. I want us all to be thinking about how are the ways in which we can develop tools to advance anti-racism in our clinical practice, in our research ethics work, in our theoretical and philosophical ethics work. How are we doing this? So I think there's some things that I want to invite if people have additional questions from these cases and thinking about additional ideas or ways of imagining how racism may have been operating in these cases, other tools or strategies the ethics consultant or other members of the team could have used. But then the next slide, we also wanted to sort of have some conversation about some bigger questions that this raises for all of us. And I'll invite any of my panelists to chime in as more questions come in, which are, how are we thinking about the role of clinical ethics? I think that there's been a lot of questions over the years of, is this our lane? Should or how can clinical ethicists and ethicists more broadly, are we positioned? Do we have the skill set, and how does our place in history and present make us attuned or able to address racism? And I think also, what is our role of considering this within our institutions? How should we be engaging with our hospital systems around racist policies and structures? So I'd invite any of the panelists who want to chime in on this, and then also we'll keep looking at the questions that are coming up in the Q&A in the chat. So if anyone wants to start us off.
I'll start it with the first question that you posed there, Jen. I think for me, kind of what we talked about at the beginning of the presentation, I think that because ethicists come from a multidisciplinary discipline, like they have so many different people and professions to draw from, I think we are equipped to address racism at like both the, like we put in the first slide, individual, interpersonal, institutional levels. And so by using systematic approaches like the ones that we are presenting here, I think it's a way for us to help recognize structural issues, but then also identify ways that we can collaborate with other people to actually make some lasting change for like the patients and families and colleagues that we have. And so I think like which are our problems? I would say that the ones that we recognize within our institution and even beyond our institution, as Alex said, that there's a role for the advocacy for the clinical ethicists, which I think is something that may be difficult for some of us to take on, but something that is in our wheelhouse should we go that way.
I like how you're saying it's in our wheelhouse. Comments that are coming in that I'm noting are people thinking we need more trainings on this that are routine. Someone asking about, can we have more, videos with patient encounters where we demonstrate how this happens? I think that it's important to recognize this as like a skill set. These are not easy things to do. Many of us in our training along the way didn't learn how to see racism. We're sort of taught, because it's so pervasive in our society, we're taught not to see it and not to recognize it and not to name it. So learning how to do that and how to intervene and how to talk to the team, the patient, the family about this is things we all need to practice all the time. And there's some questions, I don't know if folks have advice on, how do you even begin this work within your institution? I don't know if you all can speak from your experiences of starting these conversations of, we need to be doing this. Where do you start?
I can start us off answering that question. I think this is a really important question, and it's really hard, and every institution is very different, right? I work at a very privileged institution where I can consult with an office and department and consultation service that focus on healthcare equity. And so I think there's some privilege in that enables me to partner with people who truly have expertise and learn from them and work together and learn on, I think, understanding the boundaries too of ethics consultation, right? The scope, right? Where is it our role and where is it not our role to step in and somebody else should be, right? Such as an incident that's a patient safety incident that needs a different kind of approach. But I do think, in many ways, we do have the tools and do have the training. It's there at our disposal. It's really just the practice that can be hard sometimes. And so finding ways to practice with trusted colleagues, actually what you would say, and getting their feedback about it, right? Going into a consult, if you can, with another person who can check you, as you're speaking with the patient, especially if you can go in with people of multiple positionalities, because I think that can really help the conversation and help support each other in having the conversation. And so that was a recommendation I received from somebody who works in one of our DEI departments to approach, just starting the communication.
I see an interesting question about sort of engaging with this with different or with frontlines who are faced with actually incorporating these recommendations in the context of limited time and all of the institutional pressures on their time and resource constraints. I think that's a really great point, and like an inevitable thing that would and honestly probably should come up when you're recommending some of the things that we're talking about. I think one way to step back from that is thinking about our role as advocates and people who can work to shape policy and the way institutional practice operates. So like if you're being faced with that, thinking about what are the resource constraints that we could as ethicists advocate to change. I think in a small way, relatively small way, if it's an issue around nursing staffing. One practical like example of this that came up for us with some of our equity consults that came through our ethics group was around sort of communicating with families who need language interpretation for care, and that being a challenge for nurses with the way they were staffed. And so if thinking about what situations and which patients, not just in terms of their medical diagnoses, but other needs that they might have being factored in terms of what the nursing ratio is, for example. That doesn't get fully at your question around sort of what to say to that nurse who's having a hard time, because I think working through that is really important too, and creating space for everyone to voice sort of the challenges with putting all of this into practice is really important, and giving them access to the ability to talk through that, both with the ethics team and maybe with like other nurses in the institution.
And I'll add to that too, Alex, that I think one of the things that I love about having a role of an ethicist is that we actually do have some power to elevate the voices of people who may feel unheard or may feel in situations where they don't want to or can't raise their voices. And so I think that by elevating the voices of either colleagues, patients, and families, we also increase their visibility to the institution itself. And so I think it's a way to try to get more buy-in from the institution as what are the things that people are facing in the hospital. So as a way to get back to the institution to move forward and improve some of the care that we provide. But again, like I said before, it's something that's very difficult. It's easy to say, but as Gina was mentioning, being able to collaborate with other colleagues, and again, the more voices, I think, and the more visibility is probably leading to a better outcome there.
Following off of that, actually, there are several comments in the chat that I think are really important. I think, at a societal, especially maybe state legislation level, and also in the hospital, which as several people have mentioned, right, in many ways is fundamentally tied to white supremacist norms. I think it can be really hard to speak directly about racism, right? Like you can feel pressure on many fronts about writing directly about it in the chart, for example. And so one of the strategies that I think some of us have used for that is rather than, target particular people for being racist towards the patient, speaking about the facts of racism that are impinging on diagnosis, treatment, right? So we know about disparities in outcomes. We know about a perception of, about the connections between history of research and medicine and historical trauma, and how that can be triggered in real time in the clinical setting. And so we can talk about those things in the chart that are well established and fundamental to understanding harm, respectfulness, etc.
That's such an important point. And I'm just thinking, like, I think there's a lot about, it's hard to have these conversations, there's pushback for it, but remembering that the coded language of racism is present constantly in the work we did. And that, like, if you can't use that word, either because of institutional pressure, because of state laws, we also can use coded language, right? In the good ways. Like we can talk about slowing down intentionally. We can talk about trust. We have to find the same workarounds as everyone does. And just remembering that, like, I think healthcare still exists in a space where race is quite visible in the chart in a way that there's pushbacks in education. I think that's something we can use to our advantage, is that this language is constantly present already, because of not always great reasons, but anyway. I think we're approaching our time. If anyone has last comments, I was just going to note, we've been saying this throughout, we are sharing out materials. So the recording will be posted, but we also we're going to share around slides, the papers that have been written that a lot of this came from, and some of the resources that we've been gathering and creating during this event. Other wrap-up words from the panelists or from Sabrina?
Yeah, I just want to thank you all again so much for sharing with us today. This has been incredibly illuminating, and I just appreciate the theory, but also the really practical tools to carry with us into our clinical ethics work and teaching. So amazing work, and just appreciate you being here. And thanks also to everyone in the chat for great comments and questions and engagement. This is exactly what we hope this webinar series to be. So everyone have a wonderful day, and the recording will be posted on the ASBH website, and we'll figure out a way to put the resources there as well.